It's a pleasure welcoming you to tonight's Miracle of Living lecture. My name is Dr. Anthony Chen. I serve as the medical director for Torrance Memorial Physician Network, and I'm also practicing primary care medicine here at Torrance Memorial. I'll be your moderator for tonight's program, and just to make sure that everybody gets the benefit of each talk, we'll save all the questions until the Q&A session at the end of the program. First of all, I wanted to disclose that one of our speakers, Dr. Clark Fuller, who was going to talk about lung cancer screening, he's still strapped into surgery, so unfortunately, he was unable to join us tonight. Moving forward, this month's topic truly embodies the spirit of the series. Early detection saves lives, the essential cancer screenings you can't afford to skip. So tonight, we'll be focusing on 3 of the most important cancer screenings: breast cancer screening, colorectal cancer screening, and prostate cancer screening. Cancer touches nearly every family in some way, but the encouraging truth is that screening saves lives. The simple act of scheduling a test or a scan can change the course of someone's future. So our goal tonight is to make these recommendations clear and approachable. You'll hear from our outstanding specialist and a courageous cancer survivor who will share the latest updates, practical guidance, and personal insights on how you can take charge of your health or help a loved one to do the same. So for the first speaker, we have Dr. Melanie Friedlander. Dr. Friedlander is a board-certified general surgeon and the co-director of breast surgery at South Bay Surgeons. She also leads the breast surgery program at the Hunt Cancer Institute here at Torrance Memorial. Dr. Friedlander specializes in breast surgery and advanced minimally invasive techniques. Please join me in welcoming Dr. Friedlander.
I was told to make sure I lowered the mic so that you all would hear me. Hopefully you can see me over the screen as well. I didn't wear high enough heels tonight. Thank you all so much for coming this evening. The Miracle of Living talk series is very important to us because obviously, as much as we love being in the operating room fixing problems, we like proactive patients who can stay out of the operating room. That's even better. So I just want to say thank you for the opportunity and thanks for your attention. And hopefully I can figure out how to make the slides progress. Okay, here we go. So I'm not going to bore you with too many facts tonight, or at least numbers, but it is important to understand the incidence of breast cancer in this country because it's significant. According to the American Cancer Society, in 2025, the estimated incidence of breast cancer is over 316,000 new cases of invasive breast cancer in women and another 2,800 in men. On top of that, we'll see almost 60,000 cases of non-invasive breast cancer, otherwise known as DCIS, which is considered a stage 0. And those will be diagnosed in 2025 as well. So what's the lifetime chance of breast cancer? Overall, the average risk for a woman in the United States of developing breast cancer is about 1 in 8, or 13%. And obviously that increases as you get older, so it's much less likely to happen in a woman in her 30s or 40s, and a lot more likely to happen for a woman in her 70s and 80s. That also means there's a 7 in 8 chance that most women will never get breast cancer. As far as trends in breast cancer go, it's the most common cancer in American women other than skin cancer. In recent years, the incidence rates have been increasing by 0.6% per year. And that's a really important number because people are much more open and willing to talk about their breast cancer diagnosis these days. And so for a lot of people, it feels like it's happening so much more. And I get a lot of patients asking me, well, aren't more people getting breast cancer now than ever before? Well, fortunately, the answer is not really. On top of that, the death rate from breast cancer has been dropping. This is going back for almost 20 years by about 1.2% per year. These decreases are believed to be the result of finding breast cancer earlier, which is, of course, what we're here to talk about tonight, through screening and increased awareness, and also better treatments, thanks to the oncologists. When we look at 5-year survival data, it is very encouraging. I remember when I was a college student working at a hospital, I ran into a medical oncologist and I asked him, how do you manage to, I gotta stay near the mic. How do you manage to, stay focused in your practice because you take care of cancer patients all the time and that must be so depressing. And he looked at me, he was like, no, Melanie, he said, it's amazing because we cure most of them. Well, certainly in breast cancer, that's true. For a localized breast cancer, meaning that the tumor is confined within the breast, 99% of women are still alive and thriving at 5 years, and most likely they will continue to do so. For regionally advanced cancer, meaning it has gotten to the lymph nodes under the arm, there's an 87% 5-year survival. And again, these patients typically go, much further than that and eventually continue with their cure. For distant or metastatic disease, 32% of women are still around at 5 years, and many of them are thriving on maintenance therapy and living completely full lives. For all breast stages combined, a 91% survival rate at 5 years. The thing that I love most about these numbers is that when I gave a talk on breast cancer a year ago, they were actually less. So in just the space of 1 year, our 5-year survival has already improved according to all of the national data. What are the risk factors for breast cancer? Well, age, as we mentioned, younger women are less likely to get breast cancer. The longer you live, the better your chance of getting it, but it's still only 1 in 8. If you have a genetic mutation that could increase your risk for breast cancer, we're all familiar with BRCA1 and BRCA2, but there are other gene mutations that can increase your breast cancer risk as well. A family history can increase a woman's breast cancer risk by twice as much, and a personal history of breast cancer can increase your risk for future breast cancer by just a little bit. So that 1 in 8 risk of lifetime goes to 1 in 5. Dense breasts can increase your risk for breast cancer. There are high-risk breast lesions like papillomas or atypical ductal hyperplasia. Those don't always become breast cancer, but there's anywhere from a 15 to 30% chance that they can. And then, of course, there's hormone replacement. We hear about menopausal hormone use. It's a higher risk if you're using estrogen alone than if you're using estrogen in combination with progesterone. And in general, the rule of thumb is use it for a short amount of time and then try and taper off. Long-term use is what's more commonly associated with an increased risk for breast cancer. There's other lifestyle issues, obesity, alcohol use, and smoking that can also increase the breast cancer risk. So here we go with early detection. And the best way to do that is a mammogram. A lot of people think that getting different tests might be better than mammogram. Different tests are helpful, but mammogram is still the single best screening test when it comes to breast cancer. And the current recommendations are a baseline mammogram between 35 and 40 years of age, a yearly mammogram starting at 40 years of age. And then the big question is, should women stop getting a yearly mammogram? And the answer is, it depends on who you ask. So there are certainly national recommendations saying that at 55, you can start to get them every other year if you want. There are recommendations that say you can stop getting them at 74. And those are recommendations made by people that do population studies. But when I'm in an exam room with a patient, I encourage them to keep getting them every year for as long as they can. And the general rule of thumb is, if you are expecting to be here 10 years from now, you should still be getting a mammogram every year. Because again, early detection is the key. And you're going to hear me say that so many more times tonight. So for my patients, I tell them keep getting a mammogram every year, and you can stop when you want, but at least into your 80s. Again, people are living a lot longer these days, so we want to make sure that they stay well. The two most common types of mammogram we see are the 2D or two-dimensional digital mammogram. Digital just means it's an image that comes onto a computer as opposed to the old-fashioned kind where they actually develop film. You won't see that in Torrance at all. So pretty much all the facilities in the South Bay are doing digital mammograms. The advantage of that is better imaging, and the tech can see the image right away so they know if they got a good picture. There's also a 3-dimensional digital mammogram, otherwise known as tomosynthesis. That gives a lot more different images of the breast and does a 3-dimensional reconstruction. It's becoming more and more common. All of our breast centers offer this. And it's especially helpful for women with dense breasts. So if your insurance will pay for a tomosynthesis or a 3D mammogram, we always recommend it for your screening mammogram. a 2D mammogram is still excellent. What are additional screening tests that you should get? A clinical breast exam, basically getting examined by a doctor. The general recommendation is every 3 years starting at 25 years of age, and then yearly starting at 40 years of age. Breast MRI is a test that we've been using for the last 20 years, and it's incredibly helpful when it comes to making a diagnosis of breast cancer in high-risk patients or women with dense breasts. It's also very helpful for getting a better image of women's breast cancer that's already been diagnosed by biopsy. So who should be getting breast MRI? There's no definite answer. From the American College of Radiology, the American Cancer Society, and the National Cancer Institute, there are a lot of gray areas. So there aren't definitive guidelines, but in general, a woman who has a genetic mutation that increases her risk for breast cancer, a woman that has a strong family history of breast cancer, or for women that have dense breasts, it's also a very helpful test. Ultrasound is not a great screening test. It's a very labor-intensive test. It takes a very long time to screen the entire breast, and it's very technician dependent. So we don't really use it for screening so much. It's very helpful for getting another look at something you see on mammogram or MRI, or something that you feel on exam. Then there's molecular breast imaging. That's a test where they actually give a radioactive dye, and they look for different areas that light up in the breast. Molecular breast imaging has been around for a few years. Insurance plans do often cover it, and it's considered to be a very effective way of catching early cancers in dense breast tissue. It doesn't replace mammogram, but it's a very good test to use in addition to mammogram. Thermography has never really gained any traction. It was sort of a test looking for indication. It looks at different hot spots in the breast, and the problem is that there's been a lot of clinical studies that haven't shown that it's consistently reliable and that it's specific enough. So there are centers that offer it. There are women that pay cash for it. For people that want to pursue that, they certainly can. But it's not considered a routine test for breast screening, and it's not necessarily something that has been shown to be clinically reliable in testing. So what are the benefits of early detection? And of course, by early detection, we mean catching cancer early, catching it when it's small, catching it before it's moved outside the breast. The obvious answer is increased survival. We want to get to that 99% that we see for stage 1 breast cancers. Women can have smaller and less invasive surgery. For example, if you catch a breast cancer very early, then you can have a lumpectomy and save the breast. You're also going to have a better cosmetic result. And when you catch cancers early, maybe you need less treatment. You're much less likely to require chemotherapy. Sometimes we can actually even skip radiation. So we are always happy to give the least amount of treatment necessary to get the same excellent result. What are the barriers to early detection? For some people, it's a simple lack of awareness. Not every patient knows what they're supposed to get for screening tests. A lack of access. For people who live in more rural areas of the country, there may not be a mammogram facility nearby, and it may be really tough to get there. For some patients, it's a lack of insurance. Even if a mammogram isn't expensive, paying out of pocket for a mammogram and any other testing that might come from that can really add up. And then there's common misconceptions. A lot of people worry about the amount of radiation they would get with a mammogram. It's less than what you would get from an airplane traveling from here to New York. And a lot of people think that maybe mammogram isn't the best test anymore. Again, mammogram, I know I'm beating a dead horse, still the best screening test that there is for breast cancer. What else should prompt a call to a doctor? It's important, if anything changes in your breast, you contact your doctor right away, even if you had a normal mammogram a month ago. If you notice a mass in your breast or pain that seems unusual, any dimpling or retraction, indentation of the skin or nipple, changes in the shape or size of your breast, enlarged nodes under the arm, or any drainage from the nipple. It's always best to contact a doctor. And I always tell my patients, I'd rather have 10 phone calls that turn out to be nothing than miss the one I didn't get. So it's never silly to call a doctor and say, hey, I noticed something different. I'm not really sure what's going on. Let's get it checked out. If you are a breast cancer survivor, especially if you've managed to benefit from early detection, you're in good company. There are 4.3 million breast cancer survivors in the United States this year. And again, when diagnosed at an early localized stage, the 5-year survival rate for breast cancer is 99%. We know that women who have advanced breast cancer are warriors, and they fight hard and they often achieve the same survival. But for me and my purposes, I'd rather my patients fight a little less hard and find these things a little earlier. So keep getting checked. Get your mammogram every year. Call your doctor if you notice anything abnormal whatsoever, and there is no such thing as a silly question or a silly concern. Thank you very much.
Thank you, Dr. Friedlander, for the very informative and very encouraging presentation. Now we'll shift to another critical area, colorectal cancer screening, where prevention truly saves lives. Our next speaker, Dr. Neil Bhayani, is a director of cancer surgery at South Bay Surgeons. He also served as the chair of the Liver, Pancreas, and Gastrointestinal Cancer Program here at Torrance Memorial. Dr. Bhayani performs complex abdominal and cancer surgery using the latest minimally invasive techniques. So please welcome Dr. Bhayani.
Thank you all for giving up your evening to come join us. I'm going to piggyback and hit some of the same themes as Dr. Friedlander, but this is all about colorectal cancer screening. Colorectal cancer is the third most common cancer in America, and it also happens to be the third leading cause of death. It's actually surprisingly common in younger people. We tend to think of cancers as older patient problems, accumulates over time, but we're seeing a rise in colorectal cancers even in younger people. So what is colorectal cancer? So any kind of cancer is an abnormal growth, cells getting out of control. So screen left, that's kind of the anatomic version. It's an upside down U or a horseshoe is the way I typically describe it. But on the inside, what you're seeing on screen right is what the GI doctor would see on a colonoscopy. You're seeing nice, smooth lining that's reflective and with the concentric rings going downstream. So symptoms, this is one of those common things. Well, doc, I don't have any symptoms. Why should I even bother? And just like Dr. Friedlander and everybody else is going to tell you, cancer never has symptoms until it's very late. If you're waiting for it to have symptoms, you're going to have a real problem because cancers don't cause pain. Screening, the whole goal is to find cancer early because you're going looking for it. And with that, you absolutely have a higher chance of a cure. The removal of early colon cancers reduces the risk of death by 90%. Very few people with early stage colon cancer succumb to their disease. But the flip side, what are the warning signs? What should you be watching out for? When should you be worried? Well, blood in the stool. Now, there's a lot of benign reasons to have blood in the stool, but if you have that, it's really important to go and get checked out. And sometimes it's obvious. It's bright red blood or blood clots and things like that. But even tar-like stool is an indication that there's digested blood in there. If you have thin pencil stools, it may be because it's trying to squeeze through a big cancer with a small opening. People with chronic abdominal pain and cramping and bloating, that's worsening and worsening. Weight loss and fatigue are always signs of a more advanced or worrisome problem. So what does it look like? Again, pictures from a colonoscopy, you have the gamut. Top left, you have what's called a pedunculated polyp. It's like a mushroom. There's a little stalk there. You can imagine that the GI doctors can lasso that and just snip that off and take it out. Bottom left is a little bit more challenging. There's no stalk, but it's still manageable for them to get that. And then screen right, you have something that is usually just too big without any safe way of getting that out. And that's what they're looking at when they go in there. So prevention, we'll touch on this briefly. There's a lot of research on this, and unfortunately, we don't have anything that reliably will prevent colon cancer or colorectal cancers. There's been a tremendous amount of research done on aspirin. It's not going to hurt you to take a baby aspirin, whether it's 81 or 325, but most likely it's not going to make a huge change in your risk of colon cancer. Vitamin D deficiency or vitamin D replacement can, again, in small ways, incrementally change your risk of colon cancer. Plant-based diets, everyone hears a lot about this these days. Highly processed foods, including things further up the food chain like meats, contribute to all kinds of digestive cancers. And so a reduction in red meat specifically and a plant-forward or a plant-based diet can drastically reduce the risk of digestive cancers and specifically colorectal cancer. Tobacco, everybody knows that tobacco causes lung cancer. What they don't also realize is the carcinogens are not just in the air. They're transmitted through your blood into an increased risk of bladder cancer, colon cancer, stomach cancer, virtually everything. So let's get to the meat of it, screening. How do we look for it when we want to? We're going to cover 4 important aspects. There's fecal blood testing, stool DNA testing, CT colonography, and colonoscopy, and we're going to hit them one by one. I could sum this whole talk into just telling you all to go get a colonoscopy, because that is the best and most effective way of looking for colon cancer and will save everyone a lot of heartache. I would tell you that this is the first year I can stand up here and say, I just had mine. So I just turned 46. And I had my first one last year, and it really wasn't that bad. Everyone complains about the prep, and it's not a great time, but it's really not that bad. Okay, so fit testing. So once upon a time, primary care doctors used to tell you to smear your poop on a little card, and that was just looking at a chemical reaction for blood. Well, we've stepped it up. And now we have a more advanced chemical testing looking at the blood in your stool, and it's called fit testing, okay? You can see that you can buy this on Amazon and do this at home, okay? So why not do this? It's very easy, not overly expensive. What's the hitch? Okay, so really you're only looking for blood in the stool. So what you're not gonna find is a precancerous polyp, typically. What you're gonna find is a cancer. So you've missed the boat. There's a cancer there already. On top of that, you're going to miss 26% of cancers. 1/4 of colon cancers will not show up on the fit testing. Okay, so you get your fit test, and then you get a positive. Well, what do you do? Well, first of all, 15% of all the tests are positive, but that doesn't mean 15% of people have cancer. There's a tremendous number of false positive. 96% of people with a positive fit test do not have colon cancer. Think of the worry that you do when you swab that stool and you get a positive fit. And then, of course, what do you have to do when you get a positive fit? You have to go get a colonoscopy anyways, right? So you can't find a precancerous polyp. The accuracy is very suspect. Can you use it? Absolutely. Is it better than nothing? Absolutely. Stool DNA. So we upped our game once again. The world of pharmaceuticals, they came up with a way of looking not just for blood in the stool, but cancer DNA. So this is actually much more accurate. They've done head-to-head trials of over 20,000 patients, and what they found is it's good at picking up cancer. 94% of cancers will show up positive on a Cologuard test, okay? The problem is that 10% of the positives, not 96, right? 96% of the fit tests are false positives. Here, it's only 10% false positives, but that's still 1 in 10 positives, okay? It is not good at picking up precancerous polyps. Right, if you find a precancerous polyps, the GI doctors just snip it out and that's it. That's all you need. You find a cancer, then you have to come see me and have surgery. So, not good at finding the precancerous lesions. Virtual colonoscopy. Everyone gets confused by this. It's a little bit of a misnomer. It is not a colonoscopy. It is a CT scan. And there's a small amount of radiation, not a big deal. But guess what? You still have to do the colon prep because that's the only way the radiologist can tell whether that's a piece of poop in there or a polyp. So it's not accurate. You still have to do the prep. And guess what? You still need a colonoscopy if they find anything. Okay, so colonoscopy. This is where the rubber hits the road. This is what everyone should be getting. This is what it looks like if you guys haven't seen it in the actual endoscopy suite. Sigmoidoscopy. So there are places where they only look at part of the colon, the left side, the sigmoid colon. That's only 15% of the colon. And if you're going to do that, it does work to lower your risk of death, but you're not catching 85% of the colon. And you have to do it more frequently. So really, this is not recommended by anyone except insurance companies that are trying to save a lot of money. Colonoscopy is the gold standard. Not only are you finding cancers, but you can actually find and remove completely precancerous tumors. And in large studies of over 20,000 people, they're finding that about 5% of people are going to have something in there. That's 1 in 20. 1 in 20. And it is higher in men. So this is a precancerous polyp. And what you're seeing coming from the bottom 6 o'clock of the screen is the lasso that the GI doctors will use to just snip that out. Easy peasy. I could go through all the societies, but in short, everyone says just go and get a colonoscopy and it will save your life. So congratulations.
Thank you, Dr. Bhayani, for the insight on colorectal cancer prevention and screening. And I'm proud to say that I also had my colonoscopy done. Okay, so our next speaker tonight will focus on prostate cancer, one of the most common cancers in men. So please join me in welcoming Dr. Usama Mahmood, a distinguished radiation oncologist at Torrance Memorial. Dr. Mahmood earned his undergraduate and medical degree at UC Irvine, completed his residency at University of Maryland, and pursued a fellowship in advanced radiation techniques at the MD Anderson Cancer Center, where he later became an assistant professor for 5 years. Dr. Mahmood also authored and co-authored over 100 scientific papers, publications, and serves on multiple national committees. So please join me in welcoming Dr. Mahmood.
Thank you very much for the introduction. Thank you for having me. Thank you for everyone for coming to our talks today. And I first wanted to just start off by also mentioning that I also got my colonoscopy this past year. So a reminder for everyone, once you heard 45, I think is the age now that everybody should be getting it. So I'm going to be talking more about prostate cancer, and because I'm a radiation oncologist, people don't really hear about radiation very often. So I'm going to use this opportunity to also talk about what I do in my clinic because I'm very excited about it. So here's an outline of what I'm hoping to cover. But let's start with just a little bit of a review of the anatomy. So the prostate is a gland, usually walnut size, that sits on the bottom of the bladder. And let's see if I can get the pointer to work here. Oh, there it is. So it sits on the bottom of the bladder, and it sits right in front of the rectum. The rectum would be behind over here. And it's composed of 4 different zones, and shown in different colors here. And the prostate cancer is most commonly shows up in this peripheral or blue zone. And through the prostate run a few different tubes. You have the ejaculatory duct that exits from the seminal vesicle that joins with the urethra and exits out the penis. The prostate doesn't really do much for the body. It does make some of the seminal fluid, which is important for fertility reasons, but after that age is passed, then it's less of a use. In terms of the incidence and mortality of prostate cancer, if you remove benign superficial skin cancers like squamous cell carcinomas and basal cell carcinomas, prostate cancer is actually the most common malignancy among men. But in terms of mortality, it's not as impactful as second in the list. It still leads to quite a bit of number of deaths, but when you compare it to the other malignancies on this list here, the mortality rate is not as high. So the prognosis is actually a little bit better compared to other cancers. There are a number of risk factors for prostate cancer, including increasing age, ethnicity, specifically people of African descent have a higher incidence of prostate cancer. Family history can lead to increased incidence as well. And certain genetic conditions such as mutations like BRCA2 can lead to increased incidence of prostate cancer as well. A little bit more controversial is the role of things like diet and obesity. I think we're still learning about these things. There are, at least in the past, a number of symptoms that led to the diagnosis of prostate cancer, including difficulty with urination, blood in the urine or semen, erectile dysfunction, bone pain, specifically when cancer went to the bone. But nowadays, actually, it's pretty rare for patients to present with these symptoms because prostate cancer is more commonly diagnosed in an early stage due to PSA screening. So that is actually one of the big benefits of PSA screening, is that it leads to less presentation with these more advanced symptoms, thankfully. So what is PSA, or the prostate-specific antigen? It's a protein produced by both normal and malignant cells of the prostate gland. And the PSA test is a measure of a PSA in a man's blood. And in the 1980s, the FDA approved using the PSA test as a monitor for progression of prostate cancer. And in the 90s, they approved it to test asymptomatic men for prostate cancer to try to diagnose them earlier. But it's important to remember that PSA can also be elevated due to a number of benign conditions, such as enlargement of the prostate, or BPH, or inflammation of the prostate called prostatitis. So sometimes the PSA is actually increased because of these other reasons, not because of cancer. So it's important to distinguish those if possible. So unlike for breast cancer, and I think for colorectal cancer, where there's a little bit more consensus, I would say there's a little bit more controversy in general for the precise role of PSA screening for prostate cancer. The different task forces do have slightly different recommendations, and there was some confusion caused in 2018 when the USPSTF released their recommendation suggesting that you don't have to screen all men for prostate cancer. That said, the remaining guidelines from the ACS and American Urological Association and American College of Physicians are pretty unanimous that starting at about age 50, men should consider getting their prostate PSA test done. And there's a little bit variability in terms of how often you should get that done, whether it's annually or every couple of years. But suffice it to say that the majority of the guidelines do recommend PSA screening. And it's an important topic to discuss with your physicians. A lot of, important part of the discussion is, the overall health status of a male and the life expectancy, because that impacts whether or not PSA screening is felt to be indicated. So once a man presents with that elevated PSA, and if it's felt to be suspicious due to prostate cancer, there's a few steps involved that lead to diagnosis of the prostate cancer. Usually the men are referred to a urologist who will evaluate the patient, and if felt to be indicated, they'll do a biopsy. And the biopsy, if found to have cancer, will yield a Gleason score, which is a measure of how aggressive the cancer looks underneath the microscope. Once cancer has been diagnosed, then you put together a slew of information from the rectal examination, scans such as MRI, and newer PET scans called PSMA scans to give an overall stage to the patient. If cancer hasn't spread outside the prostate, which is the majority of cases with PSA screening, thankfully, we group prostate cancer into 3 different groups. You have low risk, intermediate risk, and high risk. And we look at 3 factors to see which of those groupings a man falls into. Those factors are the clinical exam, the Gleason score from the biopsy, and the PSA level. And the benefit of PSA screening is men tend to present more commonly with these lower and intermediate risk cancers versus high risk prostate cancer with PSA screening. And depending on the risk grouping that a man falls into, we have various different management options. So for a man who has actually low risk prostate cancer, one of the preferred options oftentimes is just monitoring the cancer, meaning keeping an eye on the cancer with repeated PSAs, potentially repeat biopsies, and deferring the other treatments such as surgery and radiation that can lead to side effects. That said, if a man presents with intermediate and high-risk prostate cancer, we tend not to prefer active surveillance if the man is healthy, because those cancers tend to be more aggressive and can spread and require more aggressive treatments. And the 2 standard treatments in general for prostate cancer are surgery and radiation treatment. Radiation, obviously, what I'll do, and that's what I'm hoping to go over a little bit, just because I don't think people know what radiation is and people get scared of it, and I think we are improving our techniques quite a bit. So real quickly, what radiation is, it's the emission of high energy electromagnetic waves or subatomic particles that cause ionization, a process by which the atom or molecule becomes charged. And radiation can be used for diagnosis of conditions, such as through X-rays and CT scans. And we use it in our department for treatment of cancers most commonly. And the way that it treats cancer, it causes damage to the DNA of cancer cells, and that leads to cell death. There's different types of radiation, including outside the body radiation, what we do in our department, and also internal radiation or brachytherapy, where they put radiation sources inside or next to an area where the tumor is. Especially for prostate cancer, because the external beam radiation is less invasive, that tends to be more preferred for most men. Radiation has various uses in the setting of prostate cancer. It can be used to cure the prostate cancer in what we call definitive treatment. It can be used after surgery to clean up any cells that might be left behind after surgery. Or it also can be used in a situation where cancer is spread to areas and causing problems such as bone pain. This is a typical radiation workflow. Patient first comes to our department, gets an evaluation, and we reach a decision with the patient whether or not the patient will proceed with radiation treatment. If they do, then we plan the radiation, meaning we put the patient in the position of the radiation and do a CT scan in that position. And then that information is put into our computers, and we delineate where the tumor sits and where the areas we want to avoid are. And then we put that through some computers and figure out the angles and intensity of the radiation to get as much as we can to the tumor and avoid the patient's normal tissues. And then finally, once the radiation treatment plan is composed, then we start the radiation delivery, and that can be as little as 1 treatment of radiation. Sometimes it goes on for a few weeks as well. And during that process, we obviously keep a very close eye on the patient and monitor them. And then subsequently, the patient is seen in follow-up, and where we evaluate the success of the treatment and how the patient is doing. Along this whole process, along this whole workflow, there's a lot of opportunities to improve our outcomes. And so real quick, just because I'm really excited about radiation, I'm going to talk about some of our newer techniques. We'll try to make this quick. I know that this isn't really the point of today's talk. But one of the newer techniques that we're offering is rectal spacer for prostate cancer patients. So remember, the prostate sits right in front of the rectum. And when you give radiation treatment to the prostate, in the past at least, we used to give quite a bit of radiation to the rectum. And one of the ways to avoid that is, before we do the radiation treatment, we put a little tiny needle in the space between the rectum and prostate and inject this gel that's usually 1 or 2 centimeters thick. This helps to push the prostate away from the rectum, allowing us to give more radiation to the prostate and less to the rectum and less side effects. So that's one of the newer techniques we're using. Real quick, another technique we use commonly is where we put these little metallic beads inside the prostate to help us localize the radiation to be as accurate and precise with the radiation treatment. And we're really lucky in our department, we have the latest technologies. We have the image guidance brain lab system where they use x-rays to localize where those seeds are placed and allowing us to be accurate and precise with the radiation, not only before treatment, but during the treatment process as well. This is just a picture of that again. And just to wrap things up, I'm going to go over a quick case in terms of, this kind of shows some of our newer techniques that we have. So this was a patient that I treated this past year. He started his PSA screening, and when he was found to have an elevation of 8.2. So the cut point is a little bit varies depending on how old a man can be, but 8.2 certainly is on the higher end and led to concern and referral to his urologist. And the urologist then ordered an MRI and was suspicious enough and ordered a biopsy that confirmed that there was a intermediate grade cancer on the left side of the prostate where the MRI was suspicious. And then the patient had a full body scan that showed activity only in that left side of the prostate. And he was referred to our department and decided to get radiation treatment. And this is some of the cooler things that we're doing nowadays. We're using all these different imaging modalities as part of our radiation treatment planning and delivery. So the patient's MRI, actually, you can see a little dark area. That's where the tumor and suspicious area was. That lined up really nicely with where the PSMA scan was positive. And we threw that information into our computers and created this custom radiation plan where we gave a moderate dose of radiation to the entire prostate, but to that area of concern, we gave a higher dose of radiation while avoiding sensitive things like the urethra, that goes through the middle of the prostate and the rectum that sits behind the prostate. And this patient is now going in follow-up. His PSA declined nicely with the radiation treatment, and he's doing well so far. So just to conclude, so prostate cancer is a common but often curable cancer affecting many men in the US. PSA screening is an important tool in the diagnosis of prostate cancer. Radiation treatment is one of the many options for management of prostate and other cancers, and there's a lot of advances in our field that improve the cure rates while minimizing side effects. And our department is one of the largest here in the South Bay, and it has a long history of offering these cutting-edge treatments. And this is a picture of our department here. It's very much a team approach between not only the doctors, the nurses, the radiation therapists, the front desk staff. Finally, this is a picture of my team at home. They're waiting for me to get back home. So thank you very much.
Thank you, Dr. Mahmood, for your very informative talk on prostate cancer screening, PSA, and radiation treatment as a treatment option. So next, we're honored to hear from someone who knows firsthand the power of early detection and treatment. Cancer survivor Lonzo Williams. Mr. Williams?
Did I break something? It's going to be a bad show. Good evening, everyone. My name is Lonzo Williams. As he said, I am a prostate cancer survivor. I come from the side of prostate cancer where death is kind of common. Black men pretty much die more than anyone else from prostate cancer. I didn't want to go to the doctor. I had no idea I was sick. Prostate cancer was not on my mind whatsoever. I was drugged to the doctor by my wife, and I paid for all this health insurance. We might as well use it. The doctor, he gave me the finger test, the good old finger test, the one that nobody likes. For 2 years, said your prostate's a little enlarged. We're going to watch it for a minute. Well, after about 2.5 years, it's still enlarged, and I wanted a second opinion. And they gave me the Flomax. They gave me all the stuff, all the preliminary stuff. And finally they said, oh, we're going to do a biopsy. And what's a biopsy? Oh, they're going to snip small parts of your prostate to see if you have any cancer in your prostate. And I go right here in Torrance, and of all the procedures I had, that was probably the worst one. She didn't give me any drugs, no alcohol, no nothing, and she went in the back door blazing, cutting, and this is 10 times, and she actually had a nerve to tell a joke. I've done this 100 times. I've never been hit. I said, they can't reach you. That's the only reason why they can't hit you, because they can't reach you. And it came back. I had cancer in 2 spots on my prostate. Now, for me, a proud man, here he has prostate cancer. First of all, you don't hear cancer. You don't hear prostate. All you hear is cancer. All you hear is cancer. And when I left the doctor, he gave me a bunch of pamphlets, and all I could do was cry. I sit in my car and I cried for 15 minutes. I couldn't think about nothing but dying. That was the only thing on my mind. Oh, I'm going to die. And after I wiped my eyes, after a few minutes, and finally made my way down Pacific Coast Highway to the 110 freeway, I didn't know how to tell anybody I had prostate cancer. I had no friends I could talk to about it. My wife, she don't have a prostate. She don't know nothing about this. Of course, she's going to be sympathetic, but the psychological effects of prostate cancer are starting to kick in. You want to know why? Why me? They gave me a thick book of pamphlets, and they give you all the psychological effects, denial, regret, what you could have done different, all these things. And I finally broke down, and I told my family I had prostate cancer. I had no idea how I was going to deal with it. I didn't know anything. All I knew is I was going into a state of depression. And at that time, I owned a nightclub. And I mentioned to a couple of my friends as I was going back and forth to the doctor that I was going to get my prostate checked and I might have prostate cancer. And you know how men can't keep a secret no more than women can, right? The word got out, I had cancer. And you know how when you're a kid, you tell one person something, that the dog was blue, and by the time he gets around, the dog is red with spots? By the time they got back to me, I had colon cancer, lung cancer, eyelash cancer, had every kind of cancer. And people can be very cold when they think you're going to die. People can be very cold. They were already planning my estate sale. Hey, man, what you going to do with that Cadillac in the garage? What you going to do with your studio equipment? What you going to do? I'm like, man, I'm not going anywhere just yet. So I made up my mind. I'm going to clear the air. I'm going to go to the club. And I walked on stage, and I made the announcement. I know some of y'all heard I had cancer. It's prostate cancer. They caught it early. I'm going to be okay. I'm not selling my stuff. Okay? Before I can walk off the stage, and my stage is not that big, a guy was standing on the corner. This is honest to God truth. Everything I'm telling you is actually happened, no embellishing whatsoever. I walked off the stage, and the guy told me, he looked me in the face, he said, Lonzo, I didn't know you was like that. Like what? What are you talking about? I was in jail for 4 years, and no man ever did nothing to me like that. Oh, wait a minute. You think because I had a rectal exam, I'm checking a new box. I get a ticket to the parade now. No. He said, I'll die if I let a man put his finger in my behind. I said, you probably will. I left him, and before I can walk from the stage to the bar, which is about here to that door, another guy stopped me. He says, man, that was awful brave, Lonzo. Man, I've been dealing with prostate cancer for the past 2 years. The radiation did more to me than the prostate cancer did. And I don't know what to tell him either. I walked off, checked on my cashier, and another guy stopped me. Hey, man, how you know you got prostate cancer? What's the symptoms? That answer I did know. There are no symptoms. So now, as I'm dealing with the mental anguish of having prostate cancer, I'm going through one of the stages, which is called being selfish. I'm riding down the street, and I see a bus stop. At this bus stop, there are some guys at the bus stop who do a lot of drinking and do a lot of daytime drinking. Okay, let's put it like that. They live at this bus stop, and they have a lot of daytime drinking at the by about 11 o'clock. There's a lot of empties on the side, on the curb right there. And I'm feeling real selfish, and I looked at the light, and I said, you know what? I talked to God at the light. I said, God, why I got to have this? Why not them? Why not them? I'm a pretty good guy. I do all right. And the light turned green. I went home, and I sat in my chair. And like a schoolyard bully, God hit me upside the back of my head. He said, fool, if they had it, would nobody listen? Now see, what I didn't tell y'all in my introduction is that I'm pretty popular in the hip hop world. There's this guy named Dr. Dre, billionaire guy, I raised him. Another guy named Ice Cube, I raised him. These guys came out of my camp. I'm in movies, I do documentaries. I have two of my own documentaries along with being about 35 other documentaries. In the hip hop world, I'm very famous. I'm known as the godfather of West Coast hip hop. There's nothing that came out of Compton that I didn't have my hands in. And because I have this platform, it was put upon me, I should say, to become an advocate for prostate cancer. And as I started talking about prostate cancer more and more, I started realizing that was just the tip of the iceberg of the ignorance when it comes to prostate cancer. The ignorance of prostate cancer when it comes to men and my Pope brothers, when it comes to black men, it is ridiculous. The first thing they want to know is, man, what about your sex life? I said, well, dead men don't have sex no way, so don't worry about that. Don't worry about that part. If you don't get checked, you might need, sex life will be the last thing on your list, okay? Well, how'd you treat it? Well, I had my prostate removed. I had the robotic Da Vinci. You know what I'm talking about. So I got three little dots on me. And what about radiation? Well, look, I can't tell you how to treat it, but I can just tell you what I did and what works for me. They want to know if you have it removed, how long you're going to have the ED. I call it downtime. That's the cool way to say it. Downtime. Okay? We have a little downtime. I said, well, you know what my doctor told me? My doctor works out of this hospital right here, Dr. Garrett Masadaga. And he told me something that scared me at first. I got to tell you another story first. I can tell you this story here. I was in a car wreck one time, a fatal car wreck, and my passenger died. So I got issues. I have issues. And I had to go to therapy right here at Torrance Memorial, do all the road, because they hit me on my left side, do the rotator therapy, and I hated going to therapy. I couldn't stand it, but I had to do it, okay? Well, fast forward back to prostate cancer and Dr. Garrett Masadaga. I love him right to this day. I'm gonna tell you why. Because a week after I had my operation, the good doctor says, well, Mr. Williams, I got good news and bad news. I said, what's the bad news? You're going to experience some ED. I said, what's the good news? Sex is your therapy. I said, huh? He said, sex is your therapy. He gave me a prescription for Cialis. He said, get all the sex you can as fast as you can. Are you serious? That was in 2011. I'm still in therapy right to this day. Love going to therapy, okay? But again, these are all the things that most people don't talk about. Most people don't express themselves through the way I'm able to do this. I do this on a regular basis. I do prostate cancer event. This is my new calling. I don't make records like I used to. I do prostate cancer presentations. When I was going through prostate cancer, I went to anybody I could with a white coat to try and get some sympathy or some understanding. I was at the Watts Health Care Clinic on Compton Boulevard, and I'm still going through my depression, talking to a buddy of mine, and he's in radiation, and I'm talking to him about prostate cancer. He has no idea what I'm talking about. And a doctor walks past the door. He said, hey, doc, come here for a minute, will you please? Doctor walked in, and the guy says, hey, man, my buddy just got diagnosed with prostate cancer. Could you give him some words of encouragement? And the doctor says, he asked me a couple of questions. He said, how much prostate, how many parts of your prostate had cancer? I said 2. He says, what was the percentage? I said, one was 10%, one was 15%. He looked at me with the most reassuring smile and says, man, you're not even sick. You're not even sick. He said, if you got to have cancer, you want prostate cancer or skin cancer, because if caught early, they're the earliest ones to cure. That changed my whole day. That changed my entire perspective. Now I'm not as depressed, and shortly after that, that's when I started making my trek towards being a prostate cancer advocate and making the announcement and talking about it more and more. And the more I talked about it, the more I realized it is very common. It's very common. My partner and I, Nicole, where you go, darling? Hey, baby. She and I, we've been doing a prostate cancer awareness walk in Carson. It started at Dominguez Hills, and now we brought it to my hometown of Compton. And while I was passing out flyers, because I promote this, I'm a street promoter. I put flyers in your hand. We talked. I don't want to give you too high numbers, but I would say, if I talk to a pack of men that may have been, I go to car shows. I like cars. I go to car shows and I see a pack of guys talking. I give them some flyers. If there's 20 guys there, 5 of them has either dealt with prostate cancer, dealing with prostate cancer, or know somebody that's dealing with prostate cancer. It's that common. I usually go to women's events and pass out flyers. Why? Because women will get you to go to the doctor. Women go to the doctor if their eyelashes start aching. They're going to the doctor. And when women go through various exams, whether it be the breast exam or whatever, is nothing. It's this finger is nothing. This finger is nothing. Okay, women, I pity for you. I have pity for you. I understand. So when they are the ones that's doing the motivation to get a man to go to the doctor, and sometimes I tell you, I take him by the hand, because we're not going to go unless we're bleeding someplace. We're not going to go. And that is please, if I'm wrong, correct me. Fellas, who here is a volunteer to go to the doctor without being motivated, without some kind of symptom? See? We're not going to go. If we feel like we can walk, talk, and not limp too hard, we're not going to go. And that is the problem we suffer from. And the fact that I blame this finger and the fear of this finger. I have a T-shirt that has the big X to it. In fact, on my table over there, I'm the centerfold for Pulse magazine this month, and I have a T-shirt on that says "Don't fear the finger." It's right up here. Okay. Oh, thank you. There you go. That's something I put together on my own just to have it available. Don't fear the finger, because that finger right there scares more men than the police at a crap game. Okay. That would clear a room faster than a rat in a girls' club. So, but it's all about awareness. Okay, it's all about awareness. You can't fear the finger. I talk to a lot of rough guys. I do this a lot of times. I do this. I do this in the black community. A lot of these guys are pretty rough. I'll take a bullet for my family. I'll die for my family. Will you take a finger for your family? Will you take a finger for your family? See, it's a big difference. And that just comes from the fear of the finger. And I think that fear comes from comedians. Bernie Mac, Damon Wayans, a lot of your comedians, a lot of your television shows, when it comes to men going to the doctor, they make a big deal about the finger. It could be any television show that has a male lead in it. At one point in time, there's a skit with him going to the doctor, and he didn't even kiss me. He didn't take me for a date, and it creates this phobia. And if you haven't been to the doctor, you just start having different issues unnecessarily. And I tell them all the time, I stopped making jokes about the finger because it's one of those things. Although it's obsolete, every once in a while, You got to take one for the team. So that's just part of the game. Every once in a while, you got to take one for the team. So that being said, fellas, don't feel the finger. PSA is the way. Ladies, if you have a husband, a son, a nephew, any male in your family that you care for, encourage him to go to the doctor and get a PSA test. Please. Thank you. Thank you. Thank you very much. I'm going to end on a good note. Thank y'all very much. Have a good evening. All right.
Thank you. Well, thank you, Lonzo, for your inspiring journey and your work in promoting cancer screening and keep saving lives. Thank you. So we will now open up for questions. We'll gather some questions and we'll start our Q&A session.
Members of the Miracle of Living Committee have pencil or pens and paper run around in case anybody needs one. We'll collect them and bring them to you.
Sure, okay. Thank you.
It's your life on the line.
Sure, sir, what's your question? Yes, you can go ahead and ask.
PSA screening is after you reach age 70, are you off the hook? You look like the age of 55 to 69.
Okay, so the question is on PSA screening, what do you do after age 70?
You know, the guidelines vary a little bit. I think a lot of it depends on the man's overall condition, their expected life expectancy. So for most men, once they hit age 70, they tend to have other medical issues, and the benefit of the PSA screening may not be as large, but if they're overall healthy, it should be considered and worth a conversation with the physician, I think.
You don't have to worry about it.
Not as much as when you're younger, for sure, but it still could be indicated because you know, older men do have a higher incidence of prostate cancer too. And so if you're healthy and your physician recommends it, I would definitely think it's worth doing.
Yes.
One of the most difficult things in the practice of medicine is to evaluate risk versus benefit. I haven't heard much of a discussion here as to the different risk versus benefit, and how do you decide? How do you know to rely on somebody's estimate of risk and give you percentages which are meaningless? How do you get the proper analysis of risk versus benefit when you see treatment? Doctors have a tendency not to explain that because they feel it will cause you to make a decision that is not properly evaluated. But yet there's no discussion here of risk versus benefit.
So let me just rephrase or repeat the question here. This gentleman's question is about discussion of risks and benefits when it comes to cancer screening.
Are you asking specifically about the risks of screening tests or the risks of the treatment?
Screening tests are not that necessarily invasive. Benefits are.
So you're asking about balancing the risks and benefits of actual treatment of cancer?
Right.
Okay.
Treatment, anything.
Sure. Well, I think your point is extremely well taken, and I think that's the responsibility of any physician in their conversation with the patient, because obviously it's not a doctor saying you must do this and a patient complying. It's a discussion of advantages and disadvantages, and the patient and the doctor both need to be a very important part of that discussion and decision-making process. So I do think that's the responsibility of the physician. I can only speak to my practice, where every patient I see in my office where we talk about a surgical procedure, we talk about the risks and whether it makes sense to proceed or not. So I think your point is very well taken, and I think, you know, patients do need to advocate for themselves, and those are very important questions to ask your physician anytime they're recommending a procedure.
I'll just add, in the setting of prostate cancer, that's why, there's been a trend more towards, for men who have low-risk prostate cancer that can be safely observed, to follow the active surveillance protocol, where you just keep an eye on things with PSA tests and biopsies rather than jumping to surgery and radiation. Because for those cancers, as you said, the risks of radiation or surgery probably outweighs the benefit of those treatments. So it's definitely an important part of our conversations. It's a...
It's very difficult to know what your risk benefits actually are. They see it into themselves, and they have all kinds of ideas of what they should do.
No,
This doesn't seem to have a good technique properly analyzing it.
Well, it is a complicated topic, and it's hard to balance that. The good news is there's also newer tools coming out that helps us to evaluate that risk versus benefit. For prostate cancer, for instance, there's newer genetic testing that helps us evaluate the aggressiveness of prostate cancer and helps us. So I think we're going to hopefully get better at that over time, but it's a point well taken for sure.
Okay.
Obviously, you're probably not speaking specifically about breast cancer, but I can tell you those are conversations we have all the time. And those are really important conversations, because a lot of the treatment does have potential side effects, such as chemotherapy and radiation. And even though they may not be serious side effects, they can affect quality of life long term. So we do take that very seriously. And for example, in women who are 70 years and older who have estrogen-sensitive tumors that are very, very small, we always try and minimize the treatment whenever possible. For example, those patients already have such a good prognosis that, yes, after a lumpectomy, they could have radiation, but we look at those patients and we say, you know what? Your overall survival of your cancer is so high that maybe radiation doesn't give you a significant benefit. And so even though the side effects aren't that serious, the risks aren't that high, let's eliminate that treatment, because you're probably going to be fine without it anyway. So those are conversations that we have with patients every single day. Okay. All I can say is, if you're not getting that from your physician, you should seek a second opinion, because I think that's a very valid concern on your part, and something that a physician should be able to discuss with you.
My brother is a neuroradiologist, and I discussed with him risk versus benefit. Literally, put your hands up. We don't know what's the right path. I'm 84. I don't know.
Okay. Well, thank you for...
Deal with that.
Yes. Well, thank you. If you'd like to stay later, we can discuss a little bit more in detail in respecting everybody else's time. There are a lot of questions here. And so there are a few questions for Dr. Bhayani. Here's a question. I have hemorrhoids. Will a stool DNA test of Cologuard be negative if a little bleeding from hemorrhoids?
Yeah, so both the Cologuard and the FIT test will turn positive for blood in the stool. So if you do have bleeding hemorrhoids, you will have a positive test for in those situations. And again, there's a lot of reasons to have that. So that's why you've really got to look deeper and to understand where you're going to need a colonoscopy.
Okay, thank you. The next question here is for Dr. Mahmood. It says, my dad once told me that if a man lived long enough, he would eventually get prostate cancer. Did he know what he was talking about?
I think so. There's actually a lot of men, as they get older, the incidence of prostate cancer does go up. But we're learning that some of those cancers are not very aggressive and don't require treatments. I'm going back to my residency days, but there's studies I think they've done in men who've died from other causes, let's say heart attacks, and they've studied their prostates. And I want to say about 50% of those men ended up having small amounts of distals of not aggressive cancers for the most part. So I'm not sure if it's all men will develop prostate cancer, but a good proportion will as they age. But whether or not it needs to be treated is another question.
Okay, thank you. So this is for the panel. What do you think about combining holistic or Eastern medicine with Western medicine when treating any types of cancer? It's a great question.
Yeah, I think this important topic. I think we're learning more and more about how to incorporate newer treatment modalities, including holistic medicine and Eastern medicine. And I can't think of a situation where, for prostate cancer, where we would employ that, but other cancers, for instance, for breast cancer, I think acupuncture is being used for certain situations, et cetera. And I think we're learning more and more, and I think we're definitely open to it, but I don't know if anybody else has thoughts about that.
I think it's a very important part of cancer care. Obviously, we like to practice evidence-based medicine, and what that means is looking at what the data and the science of very well-done medical studies tell us are the most effective treatments for patients, but we also take that on a case-by-case basis. And so as long as we're recommending the best possible cancer treatment for that patient, incorporating non-Western techniques, I think is fantastic, especially because in many cases it can give symptomatic relief. One of the most common issues we have in treating women with breast cancer who are postmenopausal is that they go off their hormone replacement and then they have terrible hot flashes and postmenopausal symptoms. And so there are a lot of non-prescription treatments that can help ease those symptoms. And that's one of the biggest ways where holistic or Eastern medicine techniques can really be a huge benefit to patients.
I think the question is worthwhile rephrasing to say traditional or non-scientific medicine, because some of the best research on modern scientific medicine, whether it's radiation or surgery or chemotherapy or hypertension, actually comes out of what we would traditionally think of as Eastern countries, whether it's India, China, or Japan. So I think there's a little bit of a misconception that the Eastern cultures rely heavily on those, when that's actually not true. The majority of patients treated in what we would consider Eastern cultures or Eastern countries are actually receiving scientific-based, modern, post-World War II medicine with surgery, radiation, chemotherapies for cancers, because those have been proven to be the most effective. Is there a role for combining them? Sure, but what we want is the most effective treatment.
Okay, great. Thank you for the great answers, and it's good, really good question. So next one here is more of a comment than a question. It says, please, a big thank you to Mr. Williams. I heard him loud and clear. Okay, so next question, I'll combine these two here for Dr. Mahmood. What is a high PSA? I heard is above 10. The other one is digital rectal exam.
Okay. So the PSA tends to actually increase, in the normal level PSA, quote unquote normal, tends to increase as the men get older. And that's because the prostate enlarges from benign prostatic hypertrophy, BPH, and that tends to make more PSA. So there's not actually a strict cutoff, as far as I'm aware, in terms of what is considered normal versus abnormal. One that we tend to hear a lot of is 4.0 as being a cut point, but I think it does vary a little bit with age. So a 4.0 for somebody who's 45 is very different from a 4.0 for somebody who might be 85 and has a lot of medical problems, in which case exploring biopsy and things may not be appropriate for that patient.
Thank you. And the question on DRE?
Oh, yes. That's a good question as well. So maybe you might know a little bit from the setting of colorectal cancer screening, but I'm not sure what the guidelines are in terms of whether or not DREs or digital rectal examinations are recommended for screening purposes. I do know for the setting of prostate cancer, PSA is the main screening test that we use. The DRE is considered a supplement to the PSA. So for patients who have an elevated PSA, we do tend to do a DRE to try to evaluate the prostate, but that's usually secondary.
Great, thank you. So this next question here probably is for Dr. Bhayani. I just went to my doctor for colonoscopy, and after anesthesia, my oxygen saturation went down to less than 60%. Should cardiopulmonary tests be done before colonoscopies?
Someone had a little bit of a low oxygen level after colonoscopy. Obviously, there's a multitude of reasons that could happen. A colonoscopy is a low-risk procedure done in an outpatient setting, and your doctor, GI doctor, medical doctor, needs to make sure that you're fit to have a procedure, and the setting in which it's done also needs to be appropriate. So your doctors really need to make that decision as far as what is the right situation for your testing, whatever it is. But no, on the face of it, it's a low-risk procedure, and number's a number.
Great, thank you. And so the next two-part question is also for Dr. Bhayani. Does a colonoscopy examine the full colon? If not, how much? And the second part is, when can colonoscopy screening be stopped and at what age?
Yeah, so a colonoscopy should examine the whole colon. There are situations where, whether it's a technical problem and they can't get all the way to the other end of the colon, or the prep wasn't clean enough where they don't see surfaces that are still covered with stool or fecal matter, et cetera. So there are situations where you can have an incomplete colonoscopy, but in general, the colonoscopies are complete. They look at the entire colon. As far as when to stop, there's a lot of discussion and debate there. So, the formal recommendations, which are done sort of including cost and those types of, thought processes, they say that after 80, you don't need a colonoscopy. But I think everyone here agrees that if you're in good health, then it's something to continue, just like your high blood pressure medication. No one says, well, when you're 85, you can stop taking your high blood pressure medication or your diabetes medication or whatever else. You can stop getting a haircut. If you're still alive, then you just got to take care of the body, right? So if you're going to live long enough to suffer the consequences of the problem, then you should get a colonoscopy or whatever health maintenance you need.
Great, thank you. The next question here, what can they say about people who are using ivermectin, fenbendazole, methylene blue to treat cancer?
So the question is about 3 specific chemicals used to treat cancer. As far as I know, none of those have been studied in colon or pancreas or stomach or liver cancers. Those are the cancers that I spend the most time on. So, I'm sure you can find somebody writing something on the internet or making a TikTok or an Instagram post about it. But what we deal with in our world is the compilation of hundreds of thousands of studies, compiling years and years of accumulated knowledge and data to make the best decisions for people. And, it's very disheartening when people say, I heard my Aunt Sally did this and they got all better. Well, which is great for Aunt Sally, but, we're working with the accumulated evidence of 50 years of modern medicine.
Thank you. Next question. My father and mother both died of cancer. Is there any test that I can do to test if I am predisposed of any cancers?
So obviously, it depends on the situation and the specifics of the types of cancers, but there are a number of genetic mutations that do increase risk for various types of cancer. And so if you have a significant family history for cancer, then you would probably be a candidate for genetic testing. Genetic testing is typically a blood or a saliva test, and nowadays they can test for as many as like 134 different gene mutations. The test will give you a result, and it can either be negative, which means there's no abnormalities in the genes that they specifically tested. It can show a variant of unknown significance, which is exactly what it sounds like. It's a genetic abnormality, but it's not linked to any particular disease, so it doesn't increase your risk for anything. Or it can show a genetic mutation that is linked to specific diseases, and the advantage of that is you will then know that you have that. You can do appropriate screening tests. In some situations, patients would get prophylactic surgery. For example, a woman with a BRCA1 or BRCA2 gene mutation has a significantly higher risk for breast cancer or ovarian cancer. And so those patients may choose to have prophylactic mastectomy or prophylactic removal of the ovaries to minimize their cancer risk.
Okay, thank you. Last question. This is for Dr. Mahmood. It says, I have been dealing with vocal cord cancer for many years. I have been going in once a year to get my lesion removed with laser and now twice a year. I am considering radiation. Does Torrance Memorial do target radiations where you don't radiate healthy cells?
That's a good question. First off, well, how should I answer this? First, we would evaluate a patient fully by looking at their situation. And with the radiation, when you target any area, there are going to be some normal tissue cells in the vicinity. I can't think of a situation where there won't be any normal tissue cells close by. The unique thing, though, about cancer cells is they have a propensity to want to replicate, and they're constantly dividing. So that when you cause DNA damage, whether through chemotherapy or radiation, those cancer cells tend to be a little bit more sensitive to these treatments versus normal tissue cells, which have the capabilities to repair some of that radiation damage. In the setting of larynx cancer, there are, as you can imagine, potentially sensitive structures close by that can be affected with either surgery or radiation treatment. But at our department, we do have the latest technologies we use as focused as possible, but there are definitely side effects even with very focused radiation treatments.
Great, thank you. Thank you so much. That was the last question. So I'd like to thank all of our speakers tonight for their time, for their expertise and dedication. Next, I'd like to thank everyone who helps make this Miracle of Living program possible, including the Torrance Memorial Communications team and Mary Ford. And finally, I want to thank our wonderful community for joining us tonight. We hope you leave tonight with practical knowledge and knowing that screening, and especially early screening, saves lives. So on behalf of Torrance Memorial Medical Center and the Miracle of Living program, I want to thank you all and have a wonderful evening.